Welcome to this explainer. Okay, let's be real for a second. IV pump math, it can absolutely induce pure panic, especially in the middle of a busy shift. But if you're in maternity nursing, calculating oxytocin or Pitocin dosages is literally an absolute must-know skill. We've got to ensure a safe delivery for both mom and baby, right? So we're going to break down these complex dosage calculations using a totally foolproof method, dimensional analysis. By the end of our time together, you're going to have a rock-solid, systematic way to conquer literally any Pitocin problem they throw at you.
Here is our quick roadmap for today. We'll start with the Pitocin golden rule, solve for milliliters per hour, flip the script with some reverse math, and finally, we'll beat those totally tricky clinical distractors. Let's dive in.
Section 1. The Pitocin golden rule. Before we tackle a single drop of math, we have to lay down the absolute foundation. Everything, and I mean everything we do next, relies entirely on this one single concept.
Okay, burn this metric conversion into your memory right now. 1 unit equals 1,000 milliunits. Seriously, this is your golden rule. Why? Well, because Pitocin is ordered by the healthcare provider in milliunits per minute, but the IV bag you actually grab from the supply room, that's measured in units. You're going to be constantly converting between the two, which makes this specific factor your ultimate lifeline.
And this perfectly illustrates the real-world clinical setup. Understanding how this med is actually hung helps visualize exactly why getting the math right matters so much. Pitocin is given as an IV piggyback, meaning it's infused into a primary bag of fluid, and it is always controlled strictly by an infusion pump. You aren't just doing math on a piece of paper here, you are figuring out the exact number you need to program into that relentlessly beeping digital pump right at the bedside.
Let's move right along to Section 2, solving for milliliters per hour. We're going to look at our first practical application and see how all this builds using the dimensional analysis method.
Here's our first scenario. The patient has an order for 6 millunits per minute of Pitocin, but the infusion pump only understands milliliters per hour. We know where we're starting, but our ultimate destination is milliliters per hour. So let's set up the board.
Notice how clearly we can separate what we actually hold in our hands versus what the patient needs. We've got a supplied bag reading 10 units in 1,000 milliliters of lactated ringers, and our ordered dose, 6 milliunits per minute. Let's run this whole thing through our continuous conversion sequence.
Since our goal is milliliters per hour, we've got to start with time. 60 minutes equals 1 hour. Next, we bring our minutes across and plug in our ordered dose of 6 milliunits per 1 minute. That perfectly cancels out the minutes. Now we pull from our memory bank, our golden rule, right? 1 unit is 1,000 milliunits, canceling those out. Finally, plug in the supplied bag, 1,000 milliliters contains 10 units. Look at that. By strategically canceling as we go, we are left safely at our target variables, milliliters over hours.
Okay, we have the equation set up perfectly, so how do we actually solve it? Burn this catchy mantra into your brain for exam day and your clinicals. Multiply the top, multiply the bottom, divide. It's that simple. When we multiply the entire top row, we get 360,000. Multiply the entire bottom row, we get 10,000. Then we just divide 360,000 by 10,000.
And boom, the math reveals our final pump setting. Exactly 36. So you'll confidently program that infusion pump to run at 36 milliliters per hour. Easy, right?
All right, on to Section 3, reverse math, milliunits per minute. The crucial point here is testing your adaptability by doing the exact reverse of the math we just knocked out. Think about a real clinical scenario. You might walk onto your shift, step into a patient's room, and need to verify the actual dose a laboring mother is receiving based purely on what that pump screen says. If the screen says 12 milliliters per hour, what is her actual ordered dose in milliunits per minute? We got to figure it out. Once again, let's organize our supplied variables against the current rate to keep our thoughts crystal clear before the math even begins. This time, our supplied bag has a slightly different concentration, 20 units per 1,000 milliliters, and our current rate is running at 12 milliliters per hour. We are doing the exact opposite here. Because our ultimate goal is milliunits per minute, we actually have to start with time in reverse. 1 hour equals 60 minutes. Boom, we have minute on the bottom. We bring hours across, knowing the patient gets 12 milliliters in that 1 hour, and cancel out the hours. Next, we plug in our bag's concentration of 20 units per 1,000 milliliters, which cancels the milliliters. Finally, we deploy our golden rule, 1,000 millunits per 1 unit. Units cancel out,
And look at that, we've successfully landed exactly where we need to be, milliunits per minute.
Let's apply our trusty mantra again. Multiply the top, multiply the bottom, divide. The top gives us 240,000, the bottom gives us 60,000. 240,000 divided by 60,000 is 4. We now know for an absolute fact that the mother is receiving exactly 4 milliunits per minute.
Moving into Section 4, titrating and beating distractors. Now for the ultimate real-world test. We're going to navigate a complex titration order filled with a bunch of extra clinical fluff that's honestly just designed to trip you up.
Let's look at a scenario they absolutely love to throw at you. A patient started Pitocin at 2 milliunits per minute. The provider orders the drip to be titrated by 2 milliunits every 30 minutes for a max dose of 10 milliunits, all based on contractions and fetal heart rate. The patient is doing good, 30 minutes have passed, so you increase the drip to 4 milliunits per minute. So what's your new pump setting in milliliters per hour?
This brilliantly illustrates how you just have to ignore the noise. The scenario gives us a literal mountain of data, but let's separate it out. All that distractor data, like the starting dose, the 30-minute window, the max dose. Sure, it's excellent clinical context to understand the overall patient care, but honestly, it is completely useful for solving our immediate math equation. All you actually need to know is your new target, 4 milliunits per minute, and your supplied bag, 30 units in 500 milliliters. That is the whole shebang.
We lock right into our sequence using only those need-to-know numbers. We want milliliters per hour, right? 60 minutes is 1 hour. Our new target rate is 4 milliunits per 1 minute. 1 unit is 1,000 milliunits, and our supplied bag is 500 milliliters per 30 units. Cross out the minutes, the millunits, and the units, and we've successfully isolated milliliters per hour.
One last time with the mantra. Say it with me. Multiply the top, multiply the bottom, divide. The top gives us 120,000. The bottom gives us 30,000. Divide them, and we can confidently set our pump to our final answer of 4 milliliters per hour. Nailed it.
By stripping away the distractors, remembering your core conversions, and just trusting this step-by-step framework, you have totally transformed a terrifying math problem into a highly precise tool that directly protects your patients. You now have the power to seamlessly jump between what a provider orders and what the clinical equipment actually requires. So here's my final question to you. How will you integrate this dimensional analysis strategy into your next clinical shift to ensure absolute patient safety? Thank you so much for joining me on this explainer, and keep practicing those calculations.